Welcome to our cardiovascular imaging conference. I'm Dr. William Zoghbi, chair of cardiology here. I think even my two esteemed colleagues would agree that a first line of evaluation of these prosthetic valves is, besides the clinical evaluation of whether this patient is symptomatic and what kind of valve had they put in, is an echocardiographic evaluation because it tells you about structure, but most importantly, function of these prosthetic valves. So let's delve into the topic. We have several kinds of prosthetic valves. Yes, we don't have as much ball and cage valves. Would be very rare at this stage because we don't put them anymore. But you have mechanical valves, predominantly nowadays a bileaflet prosthesis that we put, or percutaneous valves or homografts at times that may be almost indistinguishable early on from just native valves. So since with echo Doppler we evaluate certainly the Doppler evaluation, it's important to know what are the determinants of velocity and gradients, and therefore gradients across these valves. Valve size is important because the smaller the valve, for the same flow, you're going to have a higher velocity and higher gradient. Know the valve type, know the flow rate because it's very dependent. It will influence significantly what the velocities are and what the gradient is across. Also, it's important to remember that Doppler per se may be different, interrogation may be different in types of prosthesis, particularly the mechanical prosthesis where you see there two leaflets with a two-leaflet valve. You're going to have a higher velocity between these two prostheses, which may be indistinguishable when you evaluate with Doppler because it is rather in the far field. And if I superimpose here a color Doppler on top of it, you could see the acceleration of velocities. Now, when you interpolate it with Doppler, since most of these are from the apical window, it is very difficult to differentiate between them. The only time you may see a difference is for prosthetic mitral valve using a transesophageal echocardiogram. If you put the cursor between them, the velocity is a bit higher as opposed to the larger orifices. The others, we don't have an overestimation of velocities and gradients. So in a small valve, and small is 21 millimeters or below, certainly a 19 millimeter valve, there will be an overestimation of the actual gradient compared to hemodynamic assessment. And the normal values that we have already incorporate those velocities and those effective orifice areas, and that's why you see effective orifice areas are rather small for a normal valve if it is small, a bileaflet valve. Two guidelines for your reference. One is the 2009 guideline I was honored and privileged to chair, and there's another one also on percutaneous valves. And the first one is in 2009. So we're talking about 14 years later. And actually, there will be an update. I just, along with my co-authors, submitted a first version for the American Society of Echocardiography. And it's not about echo only. It is a multimodality approach. Our evaluation in collaboration with SCCT and SCMR. I think, presuming towards the end of the year, you will see something published in the Journal of the American Society of Echocardiography and other journals. What are important parameters for our evaluation? From a clinical information point of view, we need to record the date the valve replacement was performed, the type and size of the prosthesis. Many patients will have these cards on hand, so you can put that in their record, heights and weight, body surface area because of the entity of prosthesis-patient mismatch, symptoms and related clinical findings, and blood pressure and heart rate. This is an example here of a mechanical aortic prosthesis. You could see the clicks of the prosthesis, and that's what you see quite often when you have a mechanical prosthesis. A velocity of about 2.8 here, meters per second. Is this normal or is this abnormal? Remember, these prostheses are not normal valves. They're smaller unless you're dealing with a completely stentless prosthesis as well as a homograft. So most often you're going to have a higher velocity. And the question, what is normal? This is publication from us many years ago. So you know the valve type, it's St. Jude bileaflet. You know the valve size from 19 to 31 in the aortic position. And notice the heterogeneity of a mean gradient for each one of the valves. It tells you that obviously there is some flow dependency, there are some other technical factors, and the same would apply for peak gradient and peak velocity, right? So that's the same thing. And that's why we derive, using the continuity equation, an effective orifice area to incorporate flow into these measurements, and therefore you end up with an effective orifice area that is less dependent on flow changes. And you could see how tight the relation is of effective orifice area versus valve size compared in the same cohort that I showed you earlier, right? So another thing that for us in the aortic prosthesis that we use is the Doppler velocity index. We proposed that many years ago. It used to be called dimensionless index. And what this about is how much did this velocity before the prosthesis accelerate going through the prosthesis. So it's a ratio of velocities or velocity time integrals. The nice thing about it, it's a simplification of the continuity equation. And part of the reason that we could do this simplification is that the size of the prosthesis relates somewhat, not one-to-one exactly, but relates somewhat to the size of the annulus. The surgeon is going to be able to put in a larger valve if you have a larger annulus. So you take that out of the equation, and then what happens is, remember the relation that you saw with gradient, you remember the relation you saw with effective orifice area, it is rather flat. The relation is rather flat, and that's the beauty of it, meaning that if you don't know what the size of the prosthesis is, a abnormal Doppler velocity index, usually less than 0.3, tells you that there's something wrong with this valve. At least you need to take a look as to what the situation is, and in red are actually, those are documented with prosthetic valve obstruction in the aortic position. So what do they look like when you evaluate prosthesis with pulse Doppler in the LV outflow tract and CW? Usually, if you have a normal flow, ejection time gets longer, time to peak velocity is longer, time to peak acceleration is also longer. This is the acceleration time. Usually, if it is stenotic, above 100 milliseconds, and certainly if it is above 130, you could take it to the bank that this is indeed obstructed. So in this case, a mean gradient of 80, very high, Doppler velocity index of 0.18, very low, acceleration time 180 milliseconds, very, very long. And this is from the guideline 2009 guideline. Not going to change much from that point of view. Peak velocity suggests stenosis greater than 4, mean gradient greater than 35, Doppler velocity index less than 2.5, effective orifice area less than 0.8, a rounded symmetrical contour with an acceleration time that's long. We look at all these variables to try to understand it, but also at the same time, very important for the clinician and the sonographer, you have to compare the post-operative studies to the ones that you're seeing now. Why? Because each individual, it's almost like the fingerprint of that particular individual, particular valve in that body. And I think it's important because the LV outflow tract may be a little different, ejection, properties may be different. There are so many other things, and technically it may be different. So it's important to do that and then go back. Nowadays with digital technology, hopefully you can see the previous studies and compare whether there is a change. Another thing for you is if the gradient has increased, you want to know why. Is the ventricle hyperdynamic now and it wasn't before? Patient has anemia, other things. If the gradient is about the same yet it is obstructed, you have to take a look at ventricular function. Maybe stroke volume has gone down. Maybe there's an infarct in between where ventricular function has gone down. So understand the hemodynamics of that particular valve. What are the changes over time in addition to what are the changes in hemodynamics for that particular individual? So we talked about aortic. Many of these principles can also pertain to pulmonic, although we have much less data in the pulmonic position. For mitral, we use The usual, we look at mitral inflow. Remember, even a normal prosthetic valve, we're going to have higher velocities across the prosthesis, a normal on your left and obstructed on the right. We use mean gradients. We always measure and report heart rate because, as you know, mitral and tricuspid valves are gradients and hemodynamics are very dependent on heart rate, so you always do that. Pressure half time, we measure, but in a normal prosthesis, pressure half time is misleading. It may lead to larger areas than even the valve itself because it is validated, usually in obstructed valves as opposed to normal prosthetic valves. So we use for understanding effective orifice areas, the continuity equation, and this is where you use that, knowing that you cannot use it if there is significant mitral regurgitation in a mitral, or if there is significant aortic regurgitation also in a mitral position. So as I mentioned to you, maximal velocity, that's what we report, mean gradient, importance of heart rate, pressure half time, and effective regurgitation, effective orifice area. And these are some of the parameters that would suggest significant stenosis. And we're talking significant. In between, you have to compare also previous hemodynamics to that particular valve because, a small valve in a mitral position could be a 27 millimeter valve. Normally, it should be a 31 to a 33 millimeter valve. Just imagine if you have a 25 millimeter valve, which is not infrequent that you see in somebody who has calcifications in the annulus. So your gradient at baseline is high. So you need to know those hemodynamics before. So we haven't talked about TE. And the reason we haven't talked about TE is all the hemodynamics that you're looking at should be obtained from the surface echocardiogram. Actually, it gives you leeway because some of these jets are in a funny position and you may not be able to align yourself in a transesophageal. So what is the indication? Non-diagnostic or borderline cases by transthoracic, assessment of concomitant regurgitation, particularly mitral or tricuspid if you cannot see it well, maybe the etiology of a regurgitation and an aortic, right? Patients with known severe obstruction, wondering about a thrombus etiology, candidates for thrombolysis, and there are criteria actually that this center has contributed significantly to the literature and to the guidelines as to what. Importance as to the location of the prosthesis. In a mitral position, by transesophageal echocardiogram, it's almost 100% good visualization of the prosthesis, the prosthetic ring, the function, the excursion of the prosthesis, excellent. On the right side, aortic position, because you're imaging sideways to the prosthesis, success is not as good. I think realistically maybe 20-30%. And I say 20-30% meaning that I can see that these leaflets are opening and closing well as opposed to seeing a shadow. And that's why I think it's very important to be upfront and honest regarding that. And I think you will see some recommendations that actually, if I'm wondering about obstruction of a prosthesis or patient prosthesis mismatch in the aortic position, ideally it should be an X-ray, either a CT without contrast or CT with contrast if you're looking at etiology. And I know Dr. Sumin Chang will probably talk about that. Fluoroscopy, yes, you could take a look at it. Excursion, with the angulations, I think it's a bit of a lost art at this stage of the game. People are gravitating towards CT, and that's fine because here, this is an example of a normal. You could see it, and an obstructed valve where one of them is completely obstructed and the other one, excursion, is abnormal, okay? Regurgitation. You need to know what is normal regurgitation, washing jets or physiologic regurgitation, if you will, particularly in a bileaflet prosthesis. You could see it right here in the mitral position. You see these 3 jets, or depending which way you're taking a look at it. In a monoleaflet, it's a central one that at times may be impressive. This is an old one from a Starr-Edwards valve that you're not going to see anymore. From an echo point of view, very important to understand flow masking and shadowing. In an aortic position, lesser of an issue. It's not completely out, because I can see the jet going into the ventricle from either a parasternal or apical window. However, I may not see here shadowing if I have regurgitation somewhere else in the prosthesis. Mitral and tricuspid, much more of an issue, because irrespective of your position, you're hiding the jet. You're hiding visualization. If I hide visualization of 2D, I will do the same thing for the Doppler equation, which is solving the frequency shift of what happened. I always show this case. You could see the reverberations in the atrium of this ventricle, of this prosthetic valve. You tell me how bad the regurgitation is. I may see something here. I can't tell whether this is significant, yes or no, yet if you do a transesophageal, there's major dehiscence of this valve with severe regurgitation. So you could hide it completely, and therefore you need to have something to go by for you to recommend that there may be something wrong in that prosthesis from a flow point of view. High E mitral for mechanical, greater than 1.9 meter per second. High mean gradient, we're not talking about 10 millimeters of mercury, we're talking about just greater than 5 in a decent heart rate. Elevated Doppler velocity index, and here the index is inverted, greater than 2.2. A good LV function, but low systemic output in the aortic or the pulmonic area. Pulmonary hypertension, sensitive but not specific. Why? Because you may have still residual pulmonary hypertension from preoperative situation. For aortic regurgitation, lesser of an issue. The hemodynamics that we talked about and even native valves apply. You take a look at the jet. Unfortunately, quite often it may be eccentric, so you can't take a look at really color Doppler well. Take a look at the descending aorta and look at reversal of flow. Pressure halftime tells you about hemodynamics, not necessarily severity. So these are the indicators of severity. Aortic valve, LV enlargement, if this is a chronic situation, is this a new enlargement compared to post-op? Color Doppler, beware of eccentric jets. Intensity of the jet by CW, pressure halftime, regurgitant volume and fraction, and diastolic retrograde flow in the aorta. TE is very important, looking at the mechanism of regurgitation and whether there is a dehiscence. So you could see here a small abscess formation where the regurgitation is very eccentric, and this is the etiology of the regurgitation. Well, the field has evolved. It's no longer only surgical intervention and surgical replacement of these valves. Percutaneous procedures are very important in the aortic as well as the mitral. And this is the latest document from the American Society of Echocardiography and SCMR regarding that, JACE, about 4 years ago. I would refer you to that. Some of the issue of TAVR is, as opposed to a surgical dehiscence of prosthesis, it could be multiple areas that the apposition of the valve may not be as good. So that's from the start, from the initiation, as opposed to that a dehiscence or a suture abnormality or an infection occurs in a site in a prosthetic surgical valve. So the jets may be very eccentric. At times you have to go in different planes for you to be able to see them because they're all around the circumference of the prosthesis itself. They could be as eccentric as you could see right here. So you tell me by color Doppler, how can you assess the severity of this regurgitation? It will be very difficult, okay? So beware that quite a few of them will be eccentric. In the cath lab, if you're in the cath lab, you are doing either a transthoracic or a TEE. Nowadays, much less of a TEE, but most often you're gonna combine this with hemodynamic assessment in addition to an aortogram. If you're suspicious of significant regurgitation, so the interventionist can decide what to do with it, because you don't have all the parameters that you could use to assess severity of regurgitation. Now, remember that in a percutaneous, TAVI, this cage is long. This is not at the annulus of where the surgeon has sutured, the valve. So you have to do a scan of this prosthesis, of the whole cage of the prosthesis, to know where the regurgitation is coming from, and be careful about eccentric jets that would appear by color Doppler quite impressive. So you need to know where you are and you do a scan. Now, where you identify the abnormality on the scan, then you can take a look at a few things. One, its extent of the circumferential extent. Two is the size in short axis or vena contracta area, and I would use them together because at times you can have one that is quite large or one that is thin and more extensive, and this is not the only parameter that you're going to use. You're going to use other parameters to try to help you decide on the severity like we talked to you about, and this is from the guideline. So in the guideline, we have an algorithm to help you. It is a bit different, obviously, from the native valves and from the surgical valves because of what we do in percutaneous procedures, and I think that's important. Mitral can be even trickier at times, and most of the interventions nowadays, at least clinical ones, are using a TEER procedure, right? The apposition of the leaflets with the TEER procedure. And you could see that with one clip or two clips. And you can have a multitude of different jets that are residual that can be confusing. You could use vena contracta area using 3D if you are in the cath lab. We've contributed somewhat to this literature. And they could be crisscrossing. You could have multiple of them. And therefore, yes, it's important to know what you have residually, but you have to combine it with some hemodynamics. And the hemodynamics usually in this situation is very important as the pulmonary veins. And I think prognostically it has shown that it has importance. We have some data coming out. There are some data already published in the literature telling us that if you have almost resurrection of this systolic wave in the pulmonary as opposed to a systolic reversal of the pulmonary veins, your prognosis is better. Your regurgitation obviously is much less than before. And you can start seeing some spontaneous contrast even in those because you don't have this big washing jet that is coming as mitral regurgitation. From a transthoracic point of view, it may be more difficult. If I have a classic mild regurgitation, I don't need anything else. And it's mild because I barely can see a jet. No matter how you look at it, I still have a systolic wave in the pulmonary vein. My E/A ratio is not suggestive of high flow and high gradients, and I barely can record a jet. I can take this to the bank very nicely. I don't need anything else. If I see much more impressive, then you need more help. Why? Because it becomes more difficult. The jets are crisscrossing and may be quite impressive. I know it's probably moderate and above. I don't know if it is severe unless I do other quantitative findings. This is systolic reversal. At times, the jet is impinging on where the pulmonary vein is, and it may be, I wouldn't say a false positive, but it may overestimate severity. If I see an inflow like this of the mitral valve, I get concerned, right? In somebody who should have a grade 1 diastolic dysfunction and regurgitation. So you need something else. Now, by Doppler, your only other method to quantitate regurgitation is volumetric of the ventricle. Why? Because I have a prosthesis here or a clip here, and I cannot measure flow coming through the mitral annulus. I have to measure the total volume and ejection stroke volume of the ventricle. And if you're going to use that, you're going to have to use contrast because otherwise you're going to underestimate volumes and therefore underestimate the total stroke volume of the ventricle that you will compare it with either a pulmonic or an aortic flow. And we have also an algorithm for you to try to help you in this kind of situation, okay? So, in conclusion, few things regarding Doppler echo. Clinical evaluation is very important. Know the valve type and size. This is the first methodology that a clinician would use to assess prosthetic valve function. Make sure, if you're the clinician, to get a baseline echocardiogram after an intervention. Usually it is during the same admission. It may not be reflective of the steady state situation 3 to 4 months later, but it's important from a baseline. It's also important from if you need other therapies for the ventricle, if the ventricle is not doing well, etc. So we talked about that. Transthoracic is the first line method. In cases with high velocity jet and gradient, suspected stenosis or regurgitation, you do a few things. Compare previous studies. X-ray for mechanical aortic valve, and it is CT plus or minus angio. If you want the etiology, you add angio, but if you have somebody with renal dysfunction, you want to know whether the valve is moving well, you could use CT alone. TEE for others, and CMR in some cases where you need to quantitate prosthetic valve regurgitation, it's depending where it is. And I know our two speakers will expand on them, so I just wanted to summarize this quickly. All right, and with that, I think we will go to Dr. Sumin Chang, who will address CT utilization in evaluation of prosthetic valve. Sumin.
Okay, so Dr. Zoghbi did the most difficult part. Once you have the physiology and suspicion of a valve dysfunction, and you don't have still have lingering question about most of the time etiology, why the valve is obstructed or why the valve is leaking. That's when CT come into its place. So again, this is a general view of how the prosthetic valve currently that we encounter commonly looks like in CT. As you can see, it's very different, and you kind of have to get used to this. And hopefully you can have the type of surgical valve from the operating report that always help. So why do we want to do CT? So compared to echo, both TEE and TTE, the advantage is less artifact and provide better anatomical information, especially regarding the perivalvular and annular structure like myocardium, pericardium, and big vessel involvement. And allow us to do a 3D visualization of anatomical relationship, which is very useful for procedural or surgical planning. And I would argue it's a lot less invasive and more comfortable than the TEE. And the disadvantage is obviously we have to give radiation and most of the time contrast. And we barely, and the most important thing is we get very little functional information. We can get the ejection fraction. In some isolated valvular dysfunction case, we might be able to estimate the regurgitant volume and fraction, but that's very limited. And then we're still being hindered by the lower temporal resolution. So it's very important that for assessment of valve dysfunction, you have a scanner that can have very good temporal resolution. Okay, so what are the main roles? I think the main role of cardiac CT is after you establish your diagnosis or you suspect the type of dysfunction, either obstruction, regurgitation, or mix, an echo, and you still have question about what's the etiology. So let's go through some of the experiences that we have. So we'll always start with a surgical valve because that's still a lot of patients out there. And the first most common is obstruction or stenosis. So the two most common causes of obstruction besides valve degeneration is the pannus and thrombus. Pannus is usually a more long-term problem and complication, and clot could happen anytime. And most commonly, pannus is on the underside of the valve, and clot usually is in the supravalvular position, okay? And obviously, clinical characteristic is very important because if you have someone who has mechanical valve and has been inadequately anticoagulated, most likely it will be clot. And the CT can help in terms of, besides the location of the tissue that we see or mass, is the CT attenuation. So pannus is an inflammatory process, so the Hounsfield unit will be similar to soft tissue, around 100, over 100 most of the time. And clot is most of the time with a lower attenuation. So let's see some example. So this is a bioprosthetic valve. I think, this is kind of the main thing about CT is put into context from anatomical standpoint what you see in echo, right? Echo, you might be able to see some abnormality, suspicion, but with CT, kind of like everything comes into pictures and make it a lot more make more sense when you see the CT that you can see this tissue in growth, and no wonder, those will hinder the opening of the valve and cause obstruction, right? So this is an example that we had when we started our program and confirmed by surgical. So mechanical valve could have the same, again, we talk about usually an underside, and it's not a mass, it's not like a mobile mass. So you can see the impairment of the opening of the leaflet. Okay, so this is almost stuck in a closed position. So this patient had underwent explant and confirmed the presence of pannus. So again, Dr. Zoghbi mentioned X-ray technique is ideal for assessment of the opening angle and closing angle. This is the way we usually measure, okay, the angle, the closing angle between the leaflet, and when in fully open position, you measure the angle between the two leaflets, okay? So that's the bileaflet valve I saw you. This is occasionally we see single disc valve, and this is how you measure the opening angle between the disc and the annulus. This is a publication from European Heart Journal. So there's two ways of measuring it. This is usually how we measure, but if you look at manufacturer specification, especially the angle is with relationship to the plane of the annulus. So that could create a little bit of confusion, but the bottom line is, when you see the leaflet open and close, completely oppose each other, it's closing well. And if you see one of the leaflet, look asymmetric, there's some problem. So just a quick case. It's a patient with very high gradient, heart failure, had a TEE. Again, that's most of the time, as Dr. Zoghbi mentioned, you get this artifact. So there's a problem, there's a little bit of obstruction, there's a little bit of regurgitation, but what exactly is causing this? And so after the CT, you see there's two areas of the hypoattenuation structure in between the leaflet, and one is underneath the leaflet with slightly different Hounsfield unit here. Not, maybe not significant, but this, so made you wonder if this, both the two structures or two abnormality are the same. So this is the same, and the location, one is subvalvular, one is supravalvular. So patient was started with heparin, didn't really change, and then she had TPA with improvement, and you can see that one of the leaflets improved, the other leaflets still remain stuck in the position. And so the final thinking is with the TPA, we resolve the clot, which the mass is supravalvular, but does nothing to the subvalvular structure, which most likely a pannus. But it was enough for patient to get some symptomatic relief, and she was an elderly patient, so she did quite well. And this is a courtesy from Siemens. We rarely see, at least for the last several years, we rarely see any patient with a clot. Obviously, it could be mistaken by, not mistaken, could be differential diagnosis, would be a vegetation. But, giving all the structures are very preserved. There's no evidence of abscess, no clinical evidence of infection. So this was determined to be a clot. And so besides pannus and clot, the valve degeneration, especially for biological valves, and CT is very good in diagnosing, because most of the degeneration come with calcification, and non-contrast CT is very useful. This is just a outrageous case of a tricuspid valve degeneration. So you can see had both stenosis, but the valve essentially doesn't open, and it doesn't close either. So also had regurgitation, and this is how it looked like with explanted. regurgitated lesion. Regurgitation could be valvular or paravalvular. And so again, in this case, CT most of the time is ordered for procedural planning, not much for diagnosis, because I think with echo and TEE, most of the time you're gonna get the diagnosis. This is valvular or paravalvular, and I think MRI also is very helpful. CT has its caveat because a lot of this leak or gap, I like to say, because I don't like to say leak, because leak implies that you can see the blood going through. So I kind of try my best to tell the fellows that don't report paravalvular leak. You can say it's either a gap, between the tissue. So that's more honest way of presenting the problem. So when you have cases like this, this is really easy, right? I mean, you don't need to go through a cardiac, imaging fellowship to diagnose this outrageous gap in between the root and the annulus, and this is one of the worst cases that we've seen. Essentially, this that was rocking, but most of the time it's very subtle, like this one right here. I mean, this is a patient with a PVL, who also had a small VSD. And we went back to look at the echo, and only behold, there's some flow crossing, but only doing diastole. So our thinking is, maybe because this defect is so small and doing systole, everything come together, kind of occlude the VSD. So again, if you see abnormal jet, I think in echo the same when you're doing TE, if you see two different jets, you kind of have to make sure you find the origin and determine, what the problem, because not everything is paravalvular leak. Oftentimes is associated with, not oftentimes, it could associate with the small VSD. Okay. And furthermore, if you see multiple jet, like this interesting case we have, the patient who had both PVL of the aortic valve and also has PVL of the mitral valve. Okay, so it's kind of represent the same defect of the crux, but at the same time, patient also has a very large paravalvular or gap in the mitral valve. So actually the patient had both gap in the aortic associated, so actually represents the same defect with one of the mitral prosthetic gap, but at the same time, patient also had a gap in the posterior portion of the mitral prosthesis. And in echo and TE, you can clearly see there's two different separate jets. So that's important. Once you find it, you can stop. You have to keep going, make sure you see them. And most important thing is, despite having good resolution, this is probably most common what we see. This is, I'm not picking up the best case. This is just a regular case that we see most of the time. You get some artifact, and this tissue, the defect is, tissue is very, very thin. Even CT has the best spatial resolution with the motion, because most of the time this patient, tachycardic. So you could be thinking that you're seeing a defect. So you really need to have echo, especially color Doppler. You have to match. You have to always go back to, you look at your echo images, make sure the defect you're seeing has a color Doppler going through, because color Doppler, no question, the most sensitive technique to detect any regurgitation or any abnormal flow. So wherever you see in the CT, you cannot, unless you see a big hole like we saw earlier, you always have to be seeing, So this is, how about the valvular AI? I mean, this is obviously happen most of the time in patients with degenerated aortic valve. Okay, so you can see here. And again, that's why CNA image is very important. If you obtain the images in diastole, I mean, you can see this, doesn't look anything suspicious. But once you play it, you can tell, you're actually seeing only two cusps right there. So this cusp right here, the non-coronary cusp, is a problem. So you pause and rotate in diastole, you can see, and this is a fluid leaflet. You can measure it, so you can make the diagnosis. And in this case, as I mentioned earlier, an isolated prosthetic valve dysfunction. An echo, I know there was no significant mitral or tricuspid valve regurgitation. You can calculate the regurgitation fraction here. It's about 44, regurgitation volume about 45 cc. Okay, and this is give you some idea why the valve is leaking most of the time because of the degeneration. You can actually see a speckle of calcium right there, and most of the time you turn the leaflet. You can see the little piece of tissue right there, and with a little bit of image manipulation, you can have the depth looking, and you can see clearly this leaflet has restricted motion and it's essentially failed. Okay, you can see the failed part of this right here. Okay. Endocarditis, again, I think Dr. Amala presented a couple of weeks ago. This is a patient with prosthetic valve endocarditis. I thought it was an interesting case that, if you have difference of contrast between RV and LV, in this case, you can see with luck, prove that this is truly a VSD. Maybe with this very few cases like this, you don't need echo to tell you that that's a true VSD. Again, this is prosthetic valve endocarditis. Again, endocarditis has to be, the mass has to be big enough for us to see it, and if it's highly mobile because of the poor temporal resolution, small endocarditis, we will totally miss it. Okay, usually that, for the last couple of years, my slides are over, but I mean, for the last year, I would say more than half of the prosthetic valve dysfunction we look at are transcatheter valve. So we're seeing kind of like, not epidemic, but a lot of valves have been put in, starting having issues. So we're seeing a lot of transcatheter valve, and it represents its own challenge. So this is the type of prosthetic TAVI, balloon expanded, and self-expanded, okay? So number one, most common abnormality we see are degeneration. You can see heavily calcified, thickened, there's no question this is narrow, okay? Very important, non-contrast CT, okay? If you have this is a patient who has the TAVI put in less than a year ago, is in dialysis. You can see in contrast images, we didn't get too much contrast here, and the calciums are not very dense. So you look at this valve, it doesn't look too bad, but if you look at more carefully, this is a huge chunk of calcium right there. And so this patient does have moderate stenosis and echo, okay? So next is about, everyone heard about the HOLT, hypoattenuating leaflet thickness. Has been in the news since for several years. And the thinking is because of new creation of new sinus, the stagnant flow here, and that's promote thrombosis. And so usually start from the base of the leaflet and essentially extend upward and inward toward the center. And depending how thick it is, we have different, we categorize different degrees. So this is just a different grade of thickening, and in addition to the, thickness, you also have to look at the leaflet motion. You can see right here, it doesn't open as quite well. And the worst case, this is an extreme case. I mean, this is, I think one of the interventional fellows published this case in ACC case report. So, and 3D rendering, So again, we don't always get 3D image like this, depending on the image quality. So this is, again, explanted. And this doesn't happen only in transcatheter aortic valve. This could happen essentially in any transcatheter mitral valve and even surgical valve. And the key here is, in the old days, before the cardiac CT, after patient have a surgical valve put in, they don't get CT nowadays we have more CT, so we realize this phenomenon happens almost as frequently as surgical valve. Okay, so this is, okay. So in addition to this, we call thrombosis of leaflet, we're seeing right now, is also, not right now, we're paying a little more attention to the thrombosis or clot forming outside the prosthesis. Obviously, this thrombus outside the prosthesis will not affect the leaflet or the valve function, right? But this could present an embolic source. So unfortunately, no one knows what to do, and the incident is unknown. There's some report from Korea, and obviously highly biased, right? I mean, only patient with abnormal or any clinical event. So somebody even reported, incidents up to 25%, which I don't think that's the case. So this is, you could have in the sinus, Valsalva, and you could happen in other type of valve as well. So this is one of the research valve that we look at. And this is just a side note. You can see this valve has been known to cause more paravalvular leak. And I think you can have a sense that maybe the reason why is the radial force of the prosthesis is not as good. You can see it's not, the prosthesis is not fully expanded like it should be. And that could probably, I don't know, we do more study, explain why this valve actually has a little more PVL compared to balloon expanded valve. And that's one thing about CT is, I think give you the opportunity to explain a lot of clinical finding. If you look at, now we have so much detail anatomical information. So I think, if we can come out with a protocol that we don't use as much contrast or radiation, I mean, serial follow-up with CT answer a lot of clinical questions we have. I mean, this again. So that's not only places that you can have. Remember, we talk about halt of the leaflet. And there's another term, it's called HAST. It's called hyporenin subvalvular thickening. So you can see the thickening underneath the valve, maybe extending. There's a little bit of halt, but also had HAST again. And hemodynamically, probably doesn't matter, but could that cause embolic event? Do you need to put, I personally, if I see this, I probably want to be put on an equalization, but we don't know. Okay, so again, so fortunately with the new valve, the paravalvular leak has become much more uncommon, but cautious. Unlike PVL with a surgical valve, TAVI, PVL is very difficult because most of the time you don't have a huge gap, okay? Like this case, we do see a possible communication, but as I mentioned, you really need to match it with the echo, make sure this is exactly where the regurgitation jet is coming from, okay? So I would say, again, this is, if you have gap like this, it's easier to diagnose, but most of the time we don't see. And the transvalvular AI audioregistration, again, this will be similar to the surgical valve. And again, depending on the position, I think TAVI probably carry a more higher risk, although very low internal complication, VSD, compared to surgical valve, even without infection. If it's a surgical valve, you have a VSD, most likely it's abscess, fistula, but with TAVI, you can see sometimes it could be due to migration, repeated trauma, and we're seeing, I would say this year, we're seeing quite a few cases of TAVI with VSD. So again, this could be, again, this is the abscess that we talk about. And the last case I'm going to show is this very interesting case. This is a patient coming with fever, white count, repeated blood culture was negative, had a history of nickel allergy. So they did patch testing, turned out to be negative. So they put the valve in, and 5 months later, coming with this huge mass extending all the way, crossing the, causing a VSD and into the right ventricle. So And this happened to be an inflammatory mass. It's very, number one, it's very unusual to see a huge, it has to be really bad infection to cause this amount of mass. But so the patient, so this was documented by surgical. It was just inflammatory, and all the bacteriological finding was negative. Okay, I think I'm going to skip procedural planning because we don't have time, and I'll pass it to Dr. Shah, and he's going to show us also the final recommendation. When do we use cardiac CT?
So, the first question I think people always ask is, are prosthetic valves safe for MRI? So I think I want to get that out of the way. So this is not a prosthetic valve. This is a hospital bed, and that's not safe, okay? But most of the prosthetic valves, in fact, have been tested, and they're certainly up to the strength of a 4.7 Tesla scanner. They've been shown that the amount of force that can be generated by a magnetic field would not be significant enough to cause any dislocation of the valve. So the answer really to that question is really any of the prosthetic valves that we use today in practice on clinical scanners, so 1.5 Tesla or 3 Tesla scanners, the valves are safe to be utilized. So it doesn't answer the question about the 7 Tesla scanner we have over in the Research Institute, but at least for most of our clinical scanners, it's not an issue. Now, the one thing, though, you do need to be aware of is artifact, because, again, these valves have metal in them, and you can get metallic artifact that can obscure image quality. And so here's an example of one particular metallic valve, and really the magnitude of the artifact will differ depending upon the particular valve that you're dealing with. But I would say in general, especially if you're trying to do something where you want to actually look for stenosis of the valve itself, with metallic valves, assessment of stenosis is going to be hard because of the artifact that you get. Bioprosthetic valves, on the other hand, the amount of artifact you get tends to be much more manageable. Oftentimes there may be some stent struts, so you may have a little bit of artifact from that, but in fact you can still generally get a reasonable visualization of the leaflet tips. And as a result, you can use this information to try to assess for severity of stenosis by looking at the anatomic orifice area, like we do in native valves, or also by looking at the velocity, the transvalvular velocity, using our phase contrast CMR. And this is an example of one such study, which was published a few years ago from here, looking at a series of patients that had bioprosthetic valves in the aortic position. And then you can see here, using the phase contrast technique, where there's the velocity profile is measured at the level of the valve leaflet tips. And then in this example here, it was measured distal to the leaflet tips, or nowadays we would typically measure it proximal to the valve to get an assessment as a reference point. You could actually then derive what the flow is across the valve, as well as what the peak velocity is across the valve. And then similar to what you do in echocardiography, you could actually use the continuity equation to compare the velocity integral at the valve level to that either proximal or distal to the valve, where you know what the velocity where you know what the area is, and you can use that to come up with an effective orifice area by MRI. And in this particular series here of about 100 patients, there was reasonably good correlation here between Doppler-derived effective orifice area and phase contrast CMR-derived effective orifice area. So obviously, I think, as we talked about, first line approach, though, is going to be echocardiography. This is an area where CMR could be useful, but I think as we'll show in our summary slide, I think if you're looking for stenosis of prosthetic valves, CT may be more robust, in fact, than CMR. I think if we talk about prosthetic valve regurgitation, that's where I think maybe the role of MRI shines a little bit more. And again, kind of refreshing your memory to how you do assessment of native aortic regurgitation, really, one of the key approaches is to try to actually measure the flow distal to the valve, and then measure the retrograde column of blood that comes backward. So essentially, you're measuring it in the aortic root or in the ascending aorta, and this is what we would do for native valves. Similarly, you could do this for prosthetic valves. And in fact, this is showing you here an example of a patient with a transcatheter prosthesis in the aortic position, where just off of our phase contrast images, you can see if I show you this area right here, you can see there is actually flow that's going backward. You can see this also on this cross-sectional phase contrast view. In diastole, you can see that there's actually flow going backward. But the key is to try to determine what the severity of the flow is. You can measure it distal to the valve. So again, in the ascending aorta, the key here is obviously to make sure that you stay away from the location of the signal void from the valve itself, or the valve prosthesis. And then you actually just measure what the column of retrograde flow is. And in this example here, using the phase contrast, if you integrate the values together, you came up with about 45 cc's of retrograde flow. Typically, you want to get confirmatory measures, and so you can also measure proximal to the valve. So you measure flow in the left ventricular outflow tract. So here you're not trying to determine the retrograde flow, but rather what is the antegrade flow coming out of this LVOT, and compare that to what's the flow in the pulmonary artery. And in this same example patient here, when we compare the LVOT to the PA flow, that gave you about a 50 ml differential as well, suggesting in fact that there is a significant amount of aortic regurgitation. Now, you could follow this also up by doing a measure in the descending aorta to say what is is there holodiastolic retrograde flow in the descending aorta, is just another measure that increases your confidence that in fact there's significant aortic regurgitation. This patient actually went on to get aortography because he went back for a procedure. You can see they confirmed in fact significant aortic regurgitation, and this was about 6 weeks post-TAVR. He underwent a redo TAVR and did quite well clinically afterward. This was a study from a few years ago which actually looked not only at quantifying paravalvular regurgitation in these transcatheter aortic valves by MRI, but actually using that to look at prognosis. And what they found here was, in fact, when they stratified patients using a 30% marker, so those with less than 30% aortic regurgitant fraction were thought to be mild, and then those with more than 30% were thought to be moderate or severe, they saw a significant separation in outcomes in these patients from the standpoint of all-cause mortality, as well as a composite of mortality and repeat hospitalization for heart failure. So another important thing is obviously that the threshold that was associated with the worst prognosis is lower, was 30% in these paravalvular aortic regurgitation. And I think there may be several reasons for that. One is, to some extent, you almost think of this as analogous to an acute form of aortic regurgitation. These are patients that were aortic stenosis patients that all of a sudden now you remove the aortic stenosis, but you created aortic regurgitation, and as a result, this ventricle is not really compensated for aortic regurgitation. And then couple that with the fact that an AS ventricle tends to be one that has concentric hypertrophy with a smaller cavity. And so again, it's not able to tolerate a hemodynamic load. And so as a result, even a lower grade of regurgitation may have both clinical as well as prognostic significance. Now, let's look at the mitral valve, and here's an example of a patient who's got a mitral annular ring, and you'll notice there's a very eccentric jet here that we see during systole, resulting in kind of an antegrade jet. Here's another example. This is a mechanical prosthesis, and again, you can see that the artifact from the mechanical prosthesis may make it difficult for you to determine what the leaflet opening is, but you can certainly look for jets that are originating around the valve itself, and you can certainly follow the jet into the left atrium. Here's an example really of a dehiscence or partial dehiscence of this mechanical prosthesis leading to a gap, and you can also see the flow itself. The way that we would determine the severity of regurgitation here is actually very analogous to the approach that's taken for native valves, which is simply an indirect method of comparing the stroke volume that the left ventricle ejects out to the forward flow going across the aortic valve. And so again, I think one of the strengths of this approach, and this is kind of the standard approach that's used in MRI for native mitral valve assessment or tricuspid valves is it really doesn't matter whether you can visualize the leaflets, visualize at the location of the prosthesis. Rather, you're just doing an indirect volumetric assessment to say that there's a discordance between the amount of flow that the ventricle is ejecting and the amount of flow that's going forward across the aortic valve. And obviously, in the absence of a VSD, that would represent the mitral regurgitation. So in this particular example case that I showed you, the second case of a prosthetic mitral valve with dehiscence, you can see the stroke volume that this left ventricle is ejecting out is 157 cc's. And again, this is done by just planimetry of the end diastolic and end systolic volumes. Compare that to the forward flow that's going out the aorta, which is 82 cc's. And so you've got really a significant difference here. And that difference represents your mitral regurgitation, which in this case computes to about 75 mL. So indicating that there's severe paravalvular mitral regurgitation. Now, this same approach can be used post-TEER as well. And this can be done for the mitral or even for a tricuspid TEER, where you simply, as long as you can measure the stroke volume out of the ventricle, which in this case will be done, let me see if I can get this to come up here, by comparing the end diastolic and end systolic contours, and then measure the flow that's going out the great vessel. For the mitral, you'd measure flow out the aorta. If it's a tricuspid TEER, you'd want to measure flow going out the PA, and then compare the difference between the two, and that would be your measure of mitral regurgitant volume. Lastly, what about endocarditis? So I think Dr. Chang nicely talked about the limitation with CT of small, highly mobile endocarditis lesions. That limitation also applies for MRI. In this case, obviously, you've got a very nice large lesion. You can easily see it. But these small lesions that are very highly mobile and randomly mobile, you're not going to be able to see by MRI. And so as a result, you should never get an MRI to look for endocarditis. Because again, if you see it, it's fine. But if you don't see it, it doesn't exclude the presence of endocarditis. You can use MRI to look for the consequences, whether it's the regurgitation that can occur as a consequence of endocarditis, or things like abscess, dehiscence, the mechanical complications that can occur from endocarditis. That's an area where MRI could be useful, but not to make the diagnosis of endocarditis. So to wrap up here, what is CMR not optimal for? I think it's not optimal for vegetations. It's not going to be optimal for stenosis assessment of mechanical or transcatheter prosthesis, but I think it can be useful in bioprosthetic valve stenosis. Again, I think CT may be better for this role as an adjunct to echocardiography. And I think where the real strength of MRI is going to be is in valvular regurgitation, whether it's a transcatheter, a bioprosthetic, or a mechanical prosthesis. And so let me wrap up with this proposed algorithm, and I'll ask the other two speakers to come on up here as well. And I think we've talked about this before in the past, but I think that the idea really is it's got to start with a clinical assessment first, right? And so I think as Dr. Zoghbi mentioned, you got to listen to the patient, right? We always like to say echo first, but it really should be physical exam should be first. But I think when there's a suspicion, then you proceed on to transthoracic echocardiography. And then you get an idea if your concern is about endocarditis versus if your concern is about an increased velocity due to obstruction versus regurgitation. There may be different proposed pathways. I think there's a role for transesophageal echo, especially with 3D in many of these cases. And then I think in the obstruction pathway, I think really CT is probably going to be the ideal modality to go with, especially if you're talking about the aortic valve, where sometimes you may be a little bit more challenged on transesophageal echo. If you're concerned about regurgitation, I think that's where CMR may stand out better than CT. And then I think for endocarditis, as we've touched on, really TE is going to be the mainstay. There may be a role for PET if you're looking for abscess or infection. So with that, I'm going to pause, thank everyone for their attention, and then just open it up to any comments, either from the folks that are tuned in online or from anybody in the audience here.
Any questions? This is your time to ask questions. Anybody?
Any any comments regarding household units for different your connection between patents and thrombus? How good is it? I mean, how much you're deciding whether you use it thrombolytics or not? So how much do you rely on it?
I think like everything else.
Repeat the question.
Yeah, I'm sorry. The question is, if the Hounsfield unit, how do we use that to determine if it's panels versus clot and help you in deciding if the patient needs lytics or not? I think like everything else with the prosthetic valve, I mean, we don't hang on one single parameter. As I mentioned, if the patient has mechanical valve and the location is supravalvular and the anticoagulation inadequate, I think, that's fairly suggestive. But again, I think the main issue here is if the mass is big enough, the Hounsfield unit help, because remember, when you do a contrast study, if the mass is small, the adjacent contrast from the lumen gonna affect the calculation of the Hounsfield unit. So I think Hounsfield unit will help. I wouldn't use it as a primary and only reason to determine the therapy. I think the location and the clinical scenario, and if the Hounsfield unit help, I mean, that's how we use it to approach it, not just the Hounsfield unit only.
And the size is important from a safety point of view. We published on these data like a 0.8 centimeter squared, at least by transesophageal, and above, high risk for embolization. So on the right side of the heart, easy decision. On the left side of the heart, you gotta see the extent and how large this thrombus is. Other questions? All good?
All right.
All right. Thank you very much.
Oh,
Yes.
Faisal,
Faisal.
Go ahead.
I was going to ask you,
Mike.
for these TAVR valves, when you're looking at AI assessment with echo, you often see flow, but as Sumit showed you with CT, these valves often encompass quite a bit of distance from the LVOT all the way up to the ascending aorta. So how, I find it challenging when you look at it in a 2D short axis view of the valve with echo, just the flow you're seeing, whether it really made it to the LVOT.
I'm still not understanding, but I'll try to maybe, is the assessment of aortic regurgitation in a TAVI valve, right? The issues that you have in a TAVI valve, number one, the cage is long. So if I see a cage, I'm really not sure I'm at the leaflet size, at the leaflets to find out whether it is intravalvular or extravalvular, right? So for me to also decide whether it is around the cage, you're gonna have to do scanning in short axis, slowly from the top of the cage all the way down to its size. And the smallest area is your vena contracta or vena contracta area. So you can take a look at, and you have to optimize as a sonographer who's ever taken this, so you're not blooming the image itself, so you can see where the color is, and it could be punctate, it could be large in one area, it could be circumferential a little bit. So you have to go back and forth in your scanning to nail down where the vena contracta is. Because if you go further down into the ventricle, it's gonna be larger. Most of these are very eccentric. It's gonna start spraying into the alveolar tract or being in a funnel, if you will, to go in a different direction. So the scanning is very important, and you could take a look at it in the long axis, but most importantly in the short axis. Now for flow calculation by Doppler, all right, probably the same thing with MRI, is some of these valves extend quite a bit into the alveolar tract. Now, the Edwards valve is shorter usually, and it is less impinging on the alveolar tract. So usual recommendations for flow calculation is just proximal to the valve, so outside in a way of the cage, and pulse Doppler at that location. If you're into the funnel, if you're into the cage, the velocity is higher before the valve, and at the same time, your diameter is smaller because you do inner to inner diameter of the cage of the valve, right? So you want to make sure of where your pulse sample is and where your measurement is. All right. Thank you very much for your attention.